Hello, welcome to a special American Psychiatric Association Foundation video podcast, Connections to Care, Part 2. In Part 1, we listened to Donna, Dr. Hurley, and Dr. DeVido talk about how the landscape of your local community shapes the ways in which you approach connections to care. As we better understand what's involved in connecting individuals with mental illness to the care and support they need, communities should rethink how they view their involvement with jails, moving from passive participation to actively engaging in partnership with them. Let's return to the conversation between Dr. Hurley, Dr. DeVito, and Donna to learn how to do just that.
So, Donna, I was thinking about the why. We've sort of been talking about assuming you're somebody who's interested in providing integrated services to people who are justice involved, how to do that. But one of the things we haven't talked about yet is why would that be important? I mean, there's people that have an innate interest, but I'm wondering if I'm a community mental health clinician that doesn't have a particular interest necessarily in working with people who are justice involved, if I don't really have much familiarity with the courts, why would it be important for me to consider or to become familiar with all of the different domains and systems to be effective at working with the justice involved population?
Great question. And the short answer is that the person you're interested in helping, be it you call that person a community member, a client, a patient, an inmate, belongs to the community. And when that person is in jail, it's generally for a short period of time, and that person's going to come back into the community. And while they're in a jail or involved with probation or the courts, they are still a community member, and there should be in any county or community a single standard of care for whatever illness that person has, whether it's diabetes or personality disorder or opioid addiction. That person's treatment for that condition should be the same, regardless of where they're sleeping that night. And so in the best world, the jail is really is part and parcel of the community healthcare safety net. It is by default a part of the healthcare safety net because the people who use the safety net get healthcare while they're in jail. But ideally, the safety net operates in the same manner for the person's conditions, regardless of the setting the person is in, whether it's in the emergency room, in a homeless shelter, on an inpatient hospital unit, or in the jail, or in a community clinic, or in a, like I said, a homeless shelter. So that's why. Everything works best when the care is the same. And the link to the justice system vis-a-vis the courts and probation in particular has not been built to its potential strength. For a long time, people with serious mental illness have been in the court systems for the last 20 years, more and more and more every day. And the jails are default mental health treatment systems, practically inpatient units in many instances. But the clinical approach to treating the person's conditions hasn't made its way in many communities into the courts and probation because there hasn't been a joining of the providers and the justice practitioners. And by default, the justice practitioners in a lot of counties have just tried to muddle through and figure it out for themselves. And that's where you see parallel universes of provider networks that do mental health services or provide residential substance use treatment for people in the justice system that don't look anything like residential treatment for substance use for people that aren't in the justice system. That's where you see court orders, as Dr. Hurley mentioned earlier, for specific medications. That's the court practicing medicine without a license. But by default, they've had no choice. So you can join those systems together so that courts and probation people understand serious mental illness and understand addiction from their treatment perspectives the same way you do. And you can align in your approaches and your goals for that patient. And when you align in your goals, then the treatment providers align, and then the jail isn't separate from everything else anymore, and neither is the drug court. So it's ambitious, but it's also very doable because I've seen it in lots and lots of places. It doesn't take much more than some education and some good conversations between people, and maybe setting aside of a few egos here and there. But when the patient is put at the center, the client, community member, the patient is put in the center, it's not hard for people to agree on what should happen for that person.
I think there's an assumption that's based out of stigma, and anyone that's watching an APA Foundation video is probably not unaware that mental illnesses, particularly serious mental illnesses, are stigmatized, and that substance use disorders are extraordinarily stigmatized. And as a consequence, we tend to look at transient states, people who are agitated or dysregulated, and as a result of suffering, might engage in behaviors that are disruptive and potentially even criminal. That therefore those individuals must be criminals, right? Like to attribute essentially a transient state as a character flaw. And for any inpatient psychiatrists or psychiatric hospitalists that are familiar with stabilizing patients, typically with medications and other services, you can get somebody from very dysregulated to regulated with appropriate treatment. Same thing is true with substance use disorders. Recovery is absolutely possible. And there's oftentimes an assumption of, oh, great, like this is a criminal person who we've gotten into custody, and that's that. And it's not, right? Custody is almost always a transient space, right? It's not sort of a permanent solution. And that person will come out. And really the question is, when somebody is re-entering the community, are they somebody that's re-entering the community after being sort of held with no recovery support, no services, or the services that they've been provided are so different from the quality and types of services available in the community that that they haven't been appropriately supported? Or is the community invested in reducing crime and reducing recidivism and in supporting the health and wellness of everyone in the community, including community members who are justice involved, to make sure that the community standard of care is met throughout the justice continuum, right? In custody, when people are under, monitoring like probation or parole, to really wanting to give people every opportunity to thrive and not to mistake somebody's behavior in a vulnerable moment as being sort of intrinsic to their character. Because we've all seen recovery happen for people with serious mental illness, for people with substance use disorders, for people with other behavioral health conditions, when appropriate services are available. Dr. DeVido, I don't know if you have anything to elaborate on around why we should work to ensure that justice-involved populations are continuing to be seen as community members.
Well, I would echo, what both of you have said around the idea of, keeping the clinical, keeping the individual at the center of the conversation, and in particular tying this to, part of our previous conversation around the idea that the way that I've typically done that is focused on sort of the clinical needs of the individual and trying to find some alignment around that piece. And then recognizing also that then, as I think Donna put more eloquently than I could, looking at the community standard of care and holding that as a bar to which we would aspire to, is that the care that's delivered at any part of the system is equivalent in meeting that same standard of care, across the board. And and I would add that there is a sense sometimes that you know that we need to dispel from from our thinking that the experience of jail alone is disincentive enough to change behavior. And I think what we've proven time and time again is that for some individuals it is, but not many. For many individuals, it's not necessarily their choice to be incarcerated, for example, but they, because of the nature of their illness, the sort of expectation that that jail would be such a disincentive to them that they would completely change everything about their behavior and their illness, just doesn't, it doesn't pan out in terms of what we see in practice, and hence we see a lot of people for whom there's a high recidivism, because the disincentive of being in custody does not outweigh or does not overpower the illness in and of itself.
And, I'd also just add that in a system where clinicians and probation are working together on behalf of the person, and even substance use treatment providers that may be involved with the justice system or paid by Medicaid or whatever, when everybody understands the person's goals and the patient is a part of that team, then decisions can be made that really help the person stay on the path to recovery, even when a relapse happens. I mean, I've seen examples where a person is starting to spiral towards relapse in a very scary way, and all the parties agree this guy needs to spend the weekend in jail, where we can keep an eye on him and chill him out and get him back on, centered and back towards recovery. And afterwards, everyone, including the patient, agrees that was the right thing at the moment. That's a really tight treatment team with the patient in the middle of it. And that's doable.
Donna, we've alluded to the need for convening partners, right? For coordinating between many different agencies, whether those are sort of governmental agencies or, community-based organizations. And so I'll ask you directly, how do we bring in partners, right? How do we build a coalition and map out things like gaps and opportunities for the stakeholders who are involved?
So another terrific question. And in some communities, there are already processes in place, like maybe the Stepping Up Initiative or another DOJ funded initiative in the county to work on diverting people with mental illness from jail. So the first thing is to look at what's already there and see if you can build on it. And if there isn't anything there, then you have to start from scratch. Another thing is to really make a concerted effort to join the community providers with the jail providers. And sometimes the jail providers like Dr. Hurley and Dr. DeVido work in more than one setting. In many cases, the jail providers do not. They only work in the jail. They're very isolated. Nobody knows who they are. And there's a cloak of darkness over the jail, if you will. Nobody really knows what happens in there. That's pretty easy to fix. So if you reach out to the jail providers and invite them to be to get to know you and vice versa, including having the community folks tour the jail and start to understand what does go on in there, that's a great place to start. There are also opportunities in the substance use treatment arena, in particular around all the resources that are flowing towards opioid treatment right now. Whether it's, making sure that people who are on methadone or buprenorphine in the community are able to continue it when they reach the jail, whether it's making sure everybody's got Narcan when they're released from the jail or whatever. There are lots of ways to start a conversation around those things. And there's activity all over the country around those things. So, and there are also in many communities, justice involved advocacy organizations that would welcome involvement from psychiatry and the mental health system as well, directly from providers. So there's a lot. It would be a pretty rare place where nothing was already started. And there might be a lot. Sometimes there's almost too much, and making sure it stays focused on the patient and the outcomes is the most important thing. And everybody's outcomes, it's a win-win if you can get a person in the justice system stabilized in their psychiatric condition or stabilized in their substance use or both, because the person gets their life back and crime goes down. So what's not to love?
That's why building coordination between all the stakeholders is important, right? Because that's right, crime goes down, it actually improves community well-being overall.
Yep.
And I might echo what Donna, you brought up there, and just really hone in on this idea also of inviting people to enter, to actually, enter other spaces within the system. We found that was particularly powerful, especially when we think about the narcotic treatment programs, because again, another place where people really don't always understand what actually goes on and inside the walls of the narcotic treatment program. And I know as part of our efforts to enhance that relationship between our narcotic treatment program and our jail, really inviting both parties to visit both sites really had a powerful effect in terms of forging that relationship, which, you could argue that you could have had the same conversation over the phone, but there's something about seeing the space and being able to kind of imagine sort of what's happening that makes that relationship that much stronger.
Absolutely. That's a wonderful example.
So what are other ways that folks that are watching this, let's say it's mental health clinicians, or let's say it's mental health advocates, or, Jeff and I have dual hats. We're also, local administrators and policy leaders, or let's say you're at the state level, right? But how can folks advocate to ensure our community members get connected to the support that they need if they become injustice involved?
Well, I think by engaging the justice system as partners on behalf of shared population, just as we've talked about here, and once you have that engagement, you can talk about both parties can talk about the advantages and challenges of, for example, long-acting antipsychotics or long-acting buprenorphine. What does it do for the clinical, from the clinical perspective? What does it do from the justice perspective? The drain on the system. And then does that justify the price? Same with co-occurring disorders, the need to treat both. If you have that partnership of clinicians and advocates and the justice side, which needs to be the justice system. I want to make clear, we're not talking about letting people out of jail when they need to be in jail. The justice system needs to be the justice system. But the systems share this person. So if you can come to terms on the need for co-occurring treatment, for continuation of medications for psychiatric disorders and for substance use when they enter incarceration, and what that would do for the outcomes of that stay in the justice system. And also back to what Dr. DeVido said earlier, you both have strong needs for outcomes tracking, and a single system that lets you see if that person made it to their clinical appointment post incarceration and recidivated. That should be one day system, and everyone can see the benefits of that once you're talking about the patients that you share.
I was no totally makes sense. I was thinking about those community members who may not be involved with the justice system, and whether a role for organizations like NAMI or local addiction treatment advocacy organization, or even state psychiatric society. I'm wondering, is there a role for people that traditionally may not necessarily see what they do or where they advocate is necessarily being specific to justice involvement? Is there a role for kind of non-justice specific local or state-based organizations to become involved?
I do think that there's a strong call for that because you share the same clients.
Yeah.
The Psychiatric Society and the Sheriff's Association share the same people. And almost never link at the elbows on behalf of these people. And think of what could happen if you did it.
Yeah. So I've had the experience working in a correctional health to learn around the whole variety of organizations that are connected to correctional healthcare. I've opened up the National Commission on Correctional Healthcare, and which is sort of a nonprofit organization that improves quality of correctional healthcare across the United States. But I also think that there's a role for people who work in custody to be involved with the organization that work out of custody, do joint advocacy, right? So I'm involved with the American Society of Addiction and my state chapter in the California Society of Addiction Medicine, both of whom have active advocacy efforts. And for me to be able to take my experience as a correctional health psychiatrist out directly to policymakers, so people can hear exactly this is how the landscape, the policy landscape, the funding landscape, the regulatory landscape conspires to support these silos, and how there's a huge role, I think, policymaking in helping to bridge these gaps and to apply resources, rules, and regulations, support effective policy procedures, so that we can have a more uniform standard where people that see themselves in the community, but not necessarily just involved, people who work in corrections but don't necessarily see themselves community involved, actually both the justice involved community members as belonging to them.
And are vested in their outcomes.
That's right.
Absolutely. I hope one thing people will walk away from this session with is an understanding that your patients are the justice system's patients as well in many cases. And when you collaborate with that system on behalf of your patients and their patients, everybody can benefit. And your input is important and would be appreciated by the justice system partners that you have. Particularly if it's in the right setting where it's on behalf of the clients served and the community.
I think there's an assumption that gets made when people are arrested and incarcerated that the justice system has taken people who, have the mark of criminality and sort of dealt with or disposed of, whatever sentence in a way that is itself, like a self-contained, okay, this person committed a crime, now they're in custody, and now that now justice has been served. But many people who find themselves justice involved are justice involved at some of their most vulnerable points. And if we're interested in reducing crime, if we're interested in reducing the community effects of mental health problems and active substance use disorders, then we are all well served in making sure that people who are justice involved are connected to ongoing continuity effective community supports, that benefits everybody, not just the individuals who are justice involved, but it prevents crime, it prevents victimization, and it helps support the health and well-being of the community as a whole.
I think this is a very exciting time to be looking at this topic and to be having this conversation. I think that for me, I've seen a lot of changes even over the past couple of years in terms of thinking about what kinds of things can we do within the justice system to enhance all the things that we've talked about over the course of these conversations. And I would add to it to say that sometimes complexity can dissuade people or discourage people. I would also add that sometimes complexity provides an opportunity for the most excitement and for the most opportunity, frankly, for impact. So for those of you, maybe I'm speaking more specifically to those that are, maybe earlier in their journey and looking for an opportunity, looking for a place to have impact, and really encouraging you to take a look at the complexity of this situation as an opportunity to make a real big change in the lives of our community and our system at large.
Thank you for joining us for this special American Psychiatric Association Foundation video podcast. We hope this conversation provided you with the information needed to further your community and ensuring community members are connected to care. In addition to what you learned over part 1 and part 2, always remember that 2 of the questions you should be considering are: 1, did that person make it to their first appointment? And 2, did they like the provider and feel engaged? We want to extend a great thank you to Alchemies for their support in the production of this video podcast. And thank you for listening.